Brain Tumor Symposium and our webinar. Tonight, it's really my honor and privilege to introduce two of my favorite neuro-oncologists and two of my favorite people to work with. So first, we're going to hear from Dr. Mary Barden. She's an assistant professor here at Yale. And she has really focused quite a bit on enhancing and really running our inpatient neuro-oncology service. And she's done a phenomenal job with that. And she's going to start by giving us an overview in general about brain tumors, diagnoses, and things to think about when thinking about management and care. And then that will transition into Dr. Nick Blondin, who's also an assistant professor here at Yale. Nick has been with us for some time, has really built an incredible brain tumor practice, probably, I would guess, one of the busiest, if not the busiest in the state from a medical neuro-oncology standpoint. And he's going to talk to us specifically about treatment in terms of medical management, clinical trials, and the current clinical trials that we have at Yale. And then, of course, from my own shameless plug from a surgical perspective, the vast majority of brain tumors really benefit from being gross totally removed or as debulked or removed as extensively as possible. And that's certainly what we offer. But really tonight is focusing more on what happens after surgery. And with that, I will ask Dr. Barden to begin. Right before I do, though, I'll just ask anyone who has questions during the webinar, please just put them into the chat. And then we will be able to address them at the end. So now, Mary, without further ado.
All right. Can I get a thumbs up? I'm in the correct share mode. Love it. Thanks so much, Dr. Moliterno. Welcome, everyone. Thanks so much for joining us. As Dr. Moliterno said, my name is Dr. Barden. I'm one of 5 neuro-oncologists that we have in our group here. And as she also said, among us, I'm the one that you would call the neuro-onc hospitalist, meaning most of what I do, much of my day-to-day is spent taking care of brain tumor patients in the hospital or patients with cancer who have neurologic problems and are admitted to the hospital. And I'll talk a little bit more about why that's a special job, what that role is, and why it's something I'm so passionate about towards the end. But I wanted to start by sort of taking a step back and looking at the diagnosis of a brain tumor. All right, what does that mean? You, a loved one, someone you know is diagnosed with a brain tumor. How do you start to think about that? So I'll start by saying that brain tumor is a category as opposed to a diagnosis in and of itself. A tumor in the brain, just like a tumor anywhere else in the body, is going to be this abnormal growth of cells, right? The cells grow out of control, they form a tumor. But what types of cells those are, where those cells came from, how quickly and how aggressively they're growing, all of that factors into the specific type of brain tumor and what the ultimate diagnosis actually is. And the reason that's important is because different types of brain tumors are managed in very different ways. But most involving surgery, as Dr. Moliterno pointed out. The 2 major categories that we put brain tumors in are, of course, the cancerous or the malignant tumors, and then those that are benign or non-cancerous. And what's, I would say, interesting or unique, perhaps is a better term, about tumors in the brain is that regardless of which of these 2 categories they're in, they can still tend to be a problem for us. Even the benign tumors can cause pretty severe neurologic symptoms, depending on where they're located and how big they grow. And the reason for this is that, when you think about the anatomy, right, of our brain, we have a nice hard skull that protects our soft brain in between, in there, and there's just enough space for that brain to fit nice and cozy inside. And if something else starts growing that shouldn't be there, regardless of whether it's malignant or benign, it's going to start to cause you problems. It's pushing on the healthy brain around it. It's infiltrating into it, causing bleeding, things like that. So regardless of which category you're in, it's still something that typically needs to be addressed with surgery and perhaps more. And again, depending on which particular type of brain tumor, which we'll get to in a minute, the management of it could involve anything from just watching it, imaging surveillance alone. There's a few that kind of fit into that category if they don't change over time, or at the most aggressive side, getting surgery, gross total resection, followed by radiation, chemotherapy. and all that jazz. So we talked about cancerous and non-cancerous. There's a second distinction that we make when it comes to brain tumors, and that's where they came from. All right, so you have primary brain tumors, and that is a tumor that basically began in the brain and grew there and stayed there. And you have what we call a secondary brain tumor or a metastasis, and that is a cancer that began somewhere else in the body in a different organ, but then in spreading found its way to the brain and metastases formed there. If we focus on the secondary or the metastatic brain tumors for a moment, the most common ones of those that we see, I would say, are probably lung, breast, melanoma too. Part of the reason for that is that these are just the most common systemic cancers overall that we tend to see. But really virtually any type of cancer can find its way to the brain. And we see case reports of even the rare sort of systemic cancers finding their way there. So it's something we always think about if we have a patient that has known cancer elsewhere in the body that comes in with some new neurologic symptoms. Patients with systemic cancer elsewhere in the body that develop brain metastases, the cancer spreads to the brain, that's always going to be indicative of stage 4 disease. That's how we think about cancers outside the brain, is in stages, stage 1 to 4, and 4 being the most spread. Once it gets into the brain, we've hit a stage 4. Now we switch back to primary brain tumors. All right. Again, those are the ones that start in the brain and grow there. Even with that, you think that kind of narrows it down, right? It turns out there's a lot of different cells that make up the brain and sort of the supportive tissues around our neurons and things like that. And tumors can form from most of it. At the end of the day, according to the newest classification of brain tumors that came out in the beginning of 2021, there's over 100 different types of primary brain tumors that are listed. Now, most of those come from what we call glial or meningothelial cells. Glial cells are sort of, so neurons are the cells of your brain that do the firing and do the thinking and do all of that stuff. The glial cells are the cells around that support them, that keep those cells alive. So there's a lot of, the majority or a significant proportion of primary brain tumors form from abnormal growth of those glial cells. The meningothelial cells are cells that comprise the protective coating of our brain. There's sort of this coating that's between our brain itself and then the skull that's over it. And those, when they grow abnormally, can form something called a meningioma, which in its lowest grade is something that's considered benign. But again, as I said before, if it grows big enough and in the right area, it can still cause you some problems. Which leads to my next point. I often get asked by patients with new diagnoses of brain tumors, what stage is it? It must be stage 4 because I have it in my brain. We grade these, or we think about these a little bit differently than metastases, cancers that have started elsewhere and spread. We grade primary brain tumors from 1 to 4, with 1 being the most benign form, and then a grade 4 being the most aggressive or the most malignant. And what factors into that historically was mostly just histology, looking at the tumor under a microscope and seeing how aggressive and how quickly it's multiplying. But now, as we've advanced our science and we rely more on next generation sequencing, looking at the genome, the genetics of a tumor, we've identified a lot of other factors that can help us decide whether something is a more benign nature or a more aggressive grade 4 nature. And so that's also part of how we make the distinction. This is just to give you a sense of percentages of the brain tumor spread in the population. So the blue pieces of the pie are all things that are considered benign or non-malignant tumors. And over half of those is the darkest blue, which is a non-malignant or a low-grade meningioma. That in adults is by far the most common type of primary brain tumor. The red is the more malignant, and you can see about half of the more malignant types of primary brain tumors is a glioblastoma, which is essentially a grade 4 glioma. So a grade 4 tumor that grows in the glial cells. The glioblastomas are more rare than the meningiomas. But when you're thinking about a new brain tumor in an adult population, these are the two that you're generally going to be most concerned about. So how are brain tumors found? How does this come about? So most of the time, a patient's going to develop new symptoms. Okay. A lot of people know about sort of stroke risk factors, right? Either in primary care or something, primary care being like your primary medical doctor that you see. They tell you, oh, you need to look out for a drooping of the face or weakness one side of the body, having difficulties with your language or vision problems. All the same applies to a tumor. Typically, strokes are going to come on really quickly. Boom, it's like an acute event. The symptoms of a tumor are often going to develop a bit more slowly over time. So in some ways, you can kind of think of it as slow onset of stroke-like symptoms. And really, the cause of that is just like if you had a stroke in a particular area of the brain, it would cause symptoms related to what that area of the brain does. If you have a tumor growing in that area of the brain, it causes similar damage and can cause similar symptoms. Now, those are symptoms that are related to where the tumor is. You can also have symptoms that are related just to how big a tumor is and whether it's pressing on things. And that's where patients that develop new headaches or have like intractable nausea and vomiting or getting like more and more lethargic and their family's having trouble waking them up. That's where those types of symptoms come in, is when something's grown large and is increasing the pressure in the brain or blocking the outflow of the fluid in the brain that we call the cerebrospinal fluid. Another common presentation is seizures. We have an adult that comes in, never had a seizure in their life and has had a seizure for the first time with no clear cause. Invariably, they're going to get a scan of their head to see if there's a tumor there. Another way that we find these is through staging imaging or surveillance imaging. And in particular, this is going to be patients that have systemic cancer that's known. And as patients that fit into that category know, you will get staging imaging every so many months to see the status of the cancer in your body. And in some cases, or often, that it's going to include a scan of the brain or an MRI. And often in those particular patients, we will detect a tumor even before they've had symptoms. And so we can change the therapy that they're getting so that it can actually get into the brain and address it. I think the third way is incidental. And we particularly see this with lower grade tumors and meningiomas, for example. Patient gets into a car accident, has their head scanned just as part of a workup to make sure that nothing bad happened during the car accident, and they see that there's this unusual finding there. Again, that's typically going to be your more low-grade tumors that patients present that way. Okay, so to step back, you develop a symptom, be it a seizure or, sort of those slow stroke-like symptoms that I mentioned, go to the hospital. All right, what's the first thing that's going to happen? First thing that's going to happen is, well, one, you'll get examined by a neurologist, and of course, the emergency room team as well. But the second thing that's going to happen after that is you're going to get a scan of your brain. We're going to get an MRI, sometimes preceded by a CAT scan, but almost always followed by an MRI. And that really gives us a good look at what it is that we're facing. And we actually can get a pretty good sense based on the way that something looks on MRI as to what type of tumor it is, whether it's in that benign category, that malignant category, and whether it's a metastasis or something that started in the brain. It's not perfect, but we're not too bad at it. Once we've identified a tumor on the scan and we have a sense of what it may be, the next step is proving what it is and informing what we do next in our treatment, which is something that Dr. Blondin will talk about more in a little bit. And what does that involve? That involves surgery. That's Dr. Moliterno there underneath her special surgical things. Sometimes we resect tumors in their entirety. Sometimes they're just biopsied. It's a little bit beyond the scope, or certainly it's something I can answer with questions later, sort of how we decide which to do. But generally speaking, we're at least getting some of that tissue in order to make a diagnosis, and in many cases, trying to remove as much of the tumor as possible. After that, and even while a patient's in the OR, there's a pathologist on call. A piece of that tumor gets sent. They look at it under a microscope right away. Takes a little bit longer to do all the other special stains that they have and to do the genomic gene sequencing part of it. But that's where the diagnosis is made. The tumor is removed. It's looked at under the microscope. Different tests are done. And that's where we determined, is this a glioma? Is this a meningioma? Is this lymphoma? Is this a metastasis? And that's where we get our diagnosis. Now, from there forward, I'll let Dr. Blondin talk a little bit more about the treatments and clinical trials in particular for glioma, which is a lot of what we do as neuro-oncologists. But what I will do briefly before I hand it over for him is just talk a little bit about the role of the neuro-oncologist in the hospital, which again is the majority of what I do. Most patients that have a new brain tumor diagnosis, the way it's going to be found is in the hospital. Again, some people they'll be picked up incidentally or on a staging scan, but for the most part, people are going to develop new symptoms and come into the hospital, and things can precipitate pretty quickly after that. A tumor is identified and it's a bit of a whirlwind. And so this is where having, at least one of the reasons having a neuro-oncologist in the hospital is helpful to help navigate that process. So patients with brain tumors, they're often admitted to the hospital at very critical stages of their disease course. So one is the initial diagnosis I just mentioned. Two is relapse. A patient's been treated, they've been stable for a while, but then they start to have new symptoms because the tumor has regrown. It's another reason they're in the ER or in the hospital. End of life is another time that I see brain tumor patients in the hospital. Things have precipitated very quickly into a very severe status, and sort of having those conversations about, a patient's goals of care. And then also management of serious complications. The treatments that patients are on, or even just having a cancer, can predispose you to having other issues like strokes or blood clots, adverse reactions, seizures. And so patients will come into the hospital for those types of things. And these patients, sort of with all of these issues, they really benefit from having a strong neuro-oncology presence. We have a lot of neurologists in the hospital. We have a lot of medicine doctors, and these people are all very good at what they do. But for a brain tumor patient, there is a lot of nuance to understanding their disease and how it's managed, and how these little setbacks or things that happen influence things moving forward, that really a neuro-oncologist is in the best position to understand. And so having one of us there to help guide that management and provide context to other specialists from other services really helps improve the quality of care and minimizes complications, in my opinion. And it also helps ensure a seamless transition back outside the hospital, getting back to their regular neuro-oncologist and getting their routine care. So there's a person that does this, right? I keep talking about it's nice to have a neuro-oncologist that's there in the hospital. It's an oncology hospitalist, or in this case, a neuro-oncology hospitalist. This is something that we've been doing here with medical oncology for quite some time, probably over the past 4 or 5 years ago, I think. And one of the things I'm trying to do is really step into that model from the neuro-onc perspective. But really, we're not just oncologists, or we're oncologists that specialize in inpatient management, specialize in the care of patients who are hospitalized with cancer. And they have a unique set of needs. This isn't sort of review your labs, decide whether you're getting treatment that day. These are acute complications that require quick decisions and someone there to help you talk through all the options. An oncology hospitalist is going to work very closely with a multidisciplinary team. So that's going to include the nurses that are taking care of the patients, the APPs that are involved in their care, the pharmacists that are helping, choose the drugs to give them, social workers, to help establish support services and things for when they leave the hospital, as well as the other specialists. I talk to Dr. Moliterno very frequently about patients. My office is very close to hers, as she'll tell you. And, the radiologists as well, the radiation oncologists, we work together as a group. Palliative care as well, I should also mention. We work together as a group to really help optimize and create the best care plan for patients that are admitted to the hospital as we possibly can. And again, because this is primarily what we do, I'm based here. This is where most of my focus is. I'm really in the best position to help move a patient along through their course, and to help keep their primary neuro-oncologist informed about what things happen. A lot of the goal of having oncology hospitalists, and really my personal goal and passion, and why I love doing this so much, is the focus is on improving the quality and efficiency of care that patients get, and getting them really back home as soon and as safely as feasible. As many cancer patients will tell you, they don't like hanging out in the hospital. I don't blame them. The number of patients that have been like, it's nice to see you, but it's not really nice to see you. And I'm like, that's fair. Having someone like me there can significantly shorten a stay, because I know how to tell the team the next things to do and not to reinvent the wheel. And it gets patients out of the hospital faster and gets them back home, spending quality time with the people that they love. So I guess all of that's to say, this is a particular area of cancer care that I'm quite passionate about, and we're really hoping to grow within the next few years. It's been my privilege to take care of the people I have over the past year, and I think some of them are on the call. I've seen you, so thank you for joining. And I'll pass it over to Dr. Blondin now, so we have time for questions.
Well, thank you so much, Dr. Barden. It has been tremendous over the last year with you on our team. I know I really appreciate the weeks where you're on service. And I really think our team in general just does a great job on the hospital side, providing the acute care for our patients and helping guide the initial treatment. We have one question I saw, and we'll take a pause for questions before I transition to my talk. So the patient has a meningioma and under surveillance. Is there a food that I should avoid or sugar? I'll answer it first, and I'll be interested to see what Dr. Barden thinks. But I get asked this question often, and from my perspective, I don't believe meningiomas really have dietary sensitivity. Or as a metabolically driven kind of tumor. That's how we would refer to that. So I advise patients of mine to just eat a healthy diet, kind of common sense. There are certain restrictive diets like ketogenic diet or intermittent fasting that purportedly may have some anti-cancer effects, but in reality, the nutritional deficiencies that can happen with these diets negate any possible benefit and are just really difficult for folks to do. So certain meningiomas really wouldn't be affected by the diet. But an interesting factor about meningiomas is sometimes they do go dormant on their own, and it's kind of unknown why that happens or over how many years that happens. A paper I saw recently suggested that after 5 years on surveillance, a majority of meningiomas in this series seem to become dormant and stop growing. Gliomas, on the other hand, can be dormant for periods of time also, but meningiomas in particular can go dormant and then just stop growing. I don't think it was diet, it was just the biology of that. Yeah, Dr. Barden, any thoughts on your end?
I concur. I don't know of anything that specifically links particular foods with type 1 meningiomas. I think in general, your good health, so a nice, healthy, balanced diet, and don't deprive yourself too much of things you like because life is short. Eat some chocolate. It's fine.
All right. Like no other questions are appearing. So I'll transition over to my talk here. Just bear with me while I click through the right buttons. All right. Looking good? Excellent. So I'll be speaking on clinical trials for gliomas, kind of focusing on glioblastoma. Then I have a couple slides on our larger portfolio. As Dr. Moliterno mentioned, I've been with the Yale Neuro-Oncology Group since 2018. Very proud to work with our team here. I think that we really are a national center of excellence for brain tumor care. We have a lot of exciting things going on, as I'll share in the talk. It's a cool place to be right now at Yale. We really have a great team, neuro-onc, neurosurgery, radiation oncology, and the lab. I would argue really the best center in the country with the multidisciplinary care. So I'll provide some background information also, as Dr. Barden did in her talk. So focus on clinical trials. What are clinical trials? Clinical trials are research studies that test a medical, surgical, or behavioral intervention in people. Trials need to be conducted scientifically to have valid findings. And trials are the primary way that investigators can determine if a new form of treatment is safe and effective in people. So single patients taking single experimental products don't really qualify as a trial. That you need a group of patients enrolled in a trial that's been developed and has meets certain scientific rigor standards to be able to prove the finding of the trial. And there are different phases of trials. So trials have 3 phases. The phase 1 is the first in human phase. This is a drug or a treatment that was shown to be promising in lab studies or in animal models like mouse models that have human glioblastoma tissue growing in them. And we're now going to try this in people. And in phase 2 studies, a drug that was tested in phase 1 and appears to be safe to treat more people with is tested in a larger number of folks, and we're able to gain more information on safety and efficacy or effectiveness in those people. And then if a drug seems promising in phase 2, it can be entered into a phase 3 clinical trial. And phase 3 clinical trials compare an experimental treatment to the current standard of care. So in glioblastoma studies, there really are no placebo-controlled trials. Their trials compare the current standard of care treatment versus the experimental product. And every trial is different. And before a person would enroll in a clinical trial, there's an informed consent process which occurs like a long document which your study team and your physician will review with you, so you have a good understanding of what exactly is going on in this trial, your role in the trial, what stage of the development that it's at, and possible risks of participation. And again, as I mentioned, I'm focusing on gliomas. As Dr. Barden presented, gliomas are a form of cancer that develops from glial cells. And glial cells are supporting cells in the brain. They hold nerve cells in place. They help nerve cells work normally. They comprise most of the cells in the brain. I have down on the side with the pictures, the normal brain tissue is mostly this pink material. That's just where the nerves are running. And you see those purple dots are the glial cells. Within a glioblastoma tumor, there's a growth of cells, and there's too many cells. You can see there's like innumerable cells compared to normal tissue. They can line up in rows, and the presence of those cells disrupts normal brain activity. It shuts down normal neural processing, and in that way, glioblastoma causes neurological disabilities. And ultimately, as the cancer proliferates and more cells grow, more and more functions are disrupted, and a person can pass away from neurological disabilities. With gliomas, it's unknown what causes glial cells to become cancerous in the first place. There really is no leading theory on why gliomas form. It is known that they increase in incidence with older age. So they're more common in folks in their 60s, 70s compared to 20s and 30s. And they are somewhat more common in men than women. Again, kind of unknown why that is. There are now 2 different major subtypes of gliomas that have been identified based on the presence of a mutation in a gene called the IDH gene, which stands for isocitrate dehydrogenase. And the IDH gene regulates energy production in the cell. And I mentioned as gliomas cause neurological disabilities by disrupting normal brain function. So with glioma classification now, adult gliomas can be classified as IDH mutant or IDH normal. Amongst IDH mutant tumors, the 2 subtypes are astrocytomas and oligodendrogliomas. Whereas for IDH normal gliomas, these are glioblastomas. And glioblastomas have abnormal chromosome numbers, gains or losses of chromosome fragments, causing the development of that cancer. Glioblastoma is not due to a single mutation. It's due to multiple mutations and anomalies in multiple chromosomes. That's part of why glioblastoma is really difficult to treat. For IDH mutated tumors, the astrocytomas and oligodendrogliomas, there's now research efforts underway targeting the IDH mutation, and the drugs hope to impact treatment by blocking the IDH mutant effects or other effects in the cell that come downstream from the IDH mutation. So for glioblastoma or glioma treatment, the paradigm is that patients develop neurological symptoms and then a tumor will be discovered on imaging, leading to neurosurgery. At the minimum, we need a biopsy to obtain tissue and prove that a brain tumor or brain lesion seen on MRI is in fact a glioma, or know what it is. And then following diagnosis by neurosurgery, we may opt to just monitor the patient if it's a low-grade glioma or certain pediatric brain tumors, or we will recommend the patient start on treatment. And the treatment options for glioblastomas can include radiation treatment up to 6 weeks, chemotherapy treatment with Temodar as the first-line drug, tumor treating fields therapy. This is electrical field therapy delivered by the Optune device, and then enrollment in clinical trials. And then a person receives their frontline treatment or first-line treatment up until the point when relapse occurs. For nearly all folks affected by glioblastoma, the tumor will relapse at some point. The timing of that's variable, typically is measured in months, not years, although we're hoping to make efforts to lengthen that. But that is the kind of the typical prognosis for patients. And that period between the new diagnosis and the start of treatment until the first relapse is called the progression-free survival time, or PFS. Again, the PFS is an important endpoint for clinical trials. So for newly diagnosed clinical trials, a treatment is hoping to improve the progression-free survival or PFS time compared to the standard treatment, radiation, chemotherapy, or tumor treating fields. And then when relapse occurs, which also we refer to as progression of the tumor, patients can undergo second-line therapy. That can include a second surgery, a second course of radiation, second-line chemotherapies such as Avastin or Gliostine, tumor treating fields at that point, if not used previously, or it can be continued if used frontline, and then enrollment in a recurrent clinical trial. Most clinical trials are open to enrollment at the time of the first or the second recurrence. Although patients can have more recurrences, typically other lines of treatment are used beyond like a second or even third recurrence if the patient is still doing well enough to be able to receive further cancer-directed therapy. So we try to keep going with treatment until the disabilities become significant enough that a person's quality of life is really severely compromised. And we know at that time, it's the right time to transition from cancer-directed therapy to supportive measures, best supportive care, comfort measures, and ultimately a hospice program for patients. That's a really individual decision for a patient, but I think it's important to start knowing what a person would consider like a very severely compromised quality of life once like the relapse occurs. And then overall survival is the overall time from the diagnosis, your initial surgery, until the date of death. And some studies do look at overall survival as well, particularly studies that are using immunotherapy drugs. All right, let's see. I see a question appeared. So, I'll take a pause there. What is the difference between IDH mutant 1 and 2? I think that may be referring to different grades. So for IDH mutated tumors in adults, the grades are 2, 3, or 4. Adults really don't have grade 1 gliomas. Those are just present generally in children. Astrocytomas or oligodendrogliomas can, on discovery, be graded as grade 2, meaning relatively fewer amount of cells seen by the pathologist, or grade 3, meaning relatively more cells seen by the pathologist. Still, biologically, the tumor can behave similarly. For grade 4, the tumor is causing growth of blood vessels and a process called necrosis. And grade 4 tumors are growing much quicker and can behave like glioblastomas. So the grading is somewhat important, but the treatment for IDH mutated tumors still may be different in the near future compared to glioblastoma.
Dr. Blunt, I
yeah.
wonder, and maybe I'm misreading the question, but I wonder if they're referring to IDH1 mutations and IDH2 mutations.
Oh, yes. So you're right. That might be another interpretation. So these two different mutations occur in different genes. There's an IDH1 and an IDH2. And yes, they both affect the cell energy in a similar way, but they're different enzymes that may ultimately need different treatments. The drugs in development right now are for IDH1 mutated tumors. And then is work being done on MGMT gene mutation. I didn't cover MGMT gene mutation because we don't have late stage clinical trials kind of separating this, but MGMT is an enzyme that's found in some glioblastoma. The gene is controlled by a promoter region, and a promoter allows for the gene to become active or inactive. For tumors where the gene is active, the enzyme level is elevated, and the tumors are more resistant to treatment. The enzyme kind of reverses DNA damage and helps cells stay alive. So having an MGMT unmethylated or MGMT wild type tumor has worse prognosis or shorter average survival time, but it still is can be variable. Some methylated or MGMT deficient tumors can also act very aggressively. Some work Dr. Bindra in our radiation oncology division has been working on is focused on molecules that take advantage of MGMT enzyme activity. I'm not going to touch on any of those in the talk, but that it's coming up in the next year. So sign up for the 2024 program, and I'll update you then. All right, so now I'll go on to the studies that we have open in active clinical trials. Two are focusing on IDH mutant tumors, those being studies sponsored by Servier Pharmaceuticals for a drug called Boracetanib, and a consortium called the American Brain Tumor Group, ABTC, with a drug called plumeperib, or BGB-290. Then for oligodendrogliomas, which are newly diagnosed, we have a study sponsored by a cooperative group called the Alliance, which is the codel study. And then for glioblastoma, we have a number of studies open for enrollment right now, the largest of which is sponsored by another cooperative group called the Global Coalition for Adaptive Research, or GCAR. And this is the GBM Agile study, which I'm the Yale investigator for. We also have studies sponsored by biotech companies, including De Novo Biopharma, Arcus, Nanopharmaceuticals, and Kintara. So with the Indigo study, with the drug Boracetanib, this took patients with recurrent IDH mutant tumors and randomized them to receive either Boracetanib, which is an IDH enzyme inhibitor, or placebo. These were patients that were under monitoring or active surveillance with MRIs and then were found to have signs of tumor growth. At that point, they enrolled into the study and received either the drug or placebo, and the primary endpoint was the progression-free survival, or again, the time from enrollment until progression or relapse was seen. The study became closed to enrollment a few months ago, and we received a press release that this study, which was a phase 3 study, met the primary endpoint of progression-free survival, meaning the drug was effective. It delayed the time until progression-free survival compared to placebo. And this was the pivotal trial, was a phase 3 trial. So this data is going to be presented at a large medical oncology meeting in June. And then I anticipate the company will be filing with the FDA for regulatory approval of this drug. And so it will become the first drug approved for treatment of IDH mutant tumors ever. So I'm very excited about this. Again, we were a site for this. We have patients actively on this trial, and we're seeing the results and like the benefit of this treatment, which is great. So I'm looking forward to using this hopefully in the near future for other patients of mine. And then the other drug looking at IDH mutated tumors, again, was plumeperib, also going by chemical name BGB-290. In this study, patients had recurrent IDH mutant tumors and were treated open label, meaning they knew they were getting the drug, with the study drug, plumeperib, and low-dose temozolomide. The primary endpoint of this study, it was also progression-free survival. And the study's enrolled a number of patients, and we've now closed it to enrollment, and we're following patients, and data is being collected. This drug, the plumeperib, actually was discovered by Dr. Bindra's lab several years ago, and brought it into development with this company. And it's, I think, as more data is collected on how our patients are doing on the study, will be decision will be made whether to advance this into a phase 3 study or look at similar molecules called PARP inhibitors. Dr. Bindra is involved in some other efforts to develop even like further next generation PARP inhibitors. So we will have another study with this class of medications open within the next year, I believe. Now for the codel study, our codel study is for newly diagnosed patients with oligodendrogliomas. Oligodendrogliomas have a specific chromosome mutation called 1p19q co-deletion. And then they have a certain way that they look to the pathologist under the microscope called the fried egg appearance. It's the way that the cells look. It's caused somehow by this 1p19q deletion. And these tumors are particularly sensitive to chemotherapy. And the goal of the study is to determine if one chemotherapy regimen is superior to an alternative chemotherapy regimen. Both regimens are considered to be standard of care chemotherapy at this time. So the goal of the study is to collect data in a scientifically valid manner. And at some point in the future, we'll get data to know whether temozolomide or the PCV3 drug regimen is superior or inferior to the other regimen in terms of the survival outcomes for a patient and also toxicity for patients. The codel is kind of in a later iteration. An earlier version of this study looked at patients that were randomized to receive only radiation versus the radiation with chemotherapy. And it was found that the patients receiving only radiation had shorter times until the progression. So the radiation arm was closed due to this safety signal, and now there's just the two arms with the two chemotherapy regimens. So we have the study open. We encourage most newly diagnosed oligodendroglioma patients to consider enrollment in this study. It will answer an important question, and also the two chemotherapy arms are both considered standard of care. So it's really unclear to me as a neuro-oncologist if either regimen is superior, and that their trial is really a good way to go if one's facing this new diagnosis. All right, now I'll move on to our GBM studies. With the GBM Agile study, this is a large study, international now, US, Europe, Australia, and it has arms for both newly diagnosed and recurrent glioblastoma patients. The study is designed in such a way that it can start as phase 2, and then if a drug is looking promising, additional patients can be enrolled, and that arm can be converted to a phase 3 arm, with the drug ultimately becoming possible for FDA approval if it's shown to be effective. The study also has an adaptive design randomization. So for patients that enter screening for the study will assign them to an arm based on biomarkers in their tumor, like the MGMT methylation status, and also the way that the drugs seem to be performing up to that point in the enrollment. The study has one control arm of standard treatment, which is radiation and temozolomide, and that's the current gold standard treatment for newly diagnosed patients. And then a potential for unlimited experimental arms. There's currently 6 experimental arms in the study, 2 of which have been closed to enrollment, 4 are open. And this allows for more patients overall to receive experimental treatment compared to single drug clinical trials. We have the study open in New Haven and Trumbull. Here's a list of the drugs being studied. In the first arm, a drug called regorafenib was studied. This drug inhibits multiple receptors and growth pathways in the cell. It's been closed to enrollment. It's at this point not moved on to the phase 3 enrollment. It has stopped at phase 2, but data collection's ongoing. And another molecule, paxilicib, also a molecular inhibitor, also has been closed to enrollment, hasn't graduated to phase 3 at this time, but data collection is ongoing. For the arms that are open, we have VAL-083. It's a standard chemotherapy drug called a DNA alkylator. And this arm, patients receive radiation and temozolomide, followed by VAL-083 treatment as maintenance, instead of temozolomide maintenance, which is in the control arm. And then we have a new drug called VT1021. VT1021 is a molecular inhibitor, which recently opened to enrollment. This affects cell growth in a number of different pathways. In the models and in small studies, it appears to induce cell death in tumor cells. It also has some immunotherapy properties, and it blocks blood vessel growth to prevent oxygen delivery. So it's an exciting molecule given IV. Then another arm is with troriluzole. Troriluzole is an oral medication that blocks glutamate, a neurotransmitter involved in tumor growth and tumor cell communication. There's some solid preclinical or lab evidence that blocking glutamate should slow GBM growth. So this study, in this arm, patients take radiation and temozolomide, and then troriluzole is an add-on therapy in addition to temozolomide. And then we have another drug which will be opening later this year called ADIPEG-20. The ADIPEG-20 is given via injections, and it's an arginine depleting enzyme. Arginine is an amino acid, which is a building block of proteins. It was discovered that GBM can't produce arginine molecules in their cells, whereas healthy tissue can. So glioblastoma absorbs arginine from the bloodstream to allow the cell to grow. And by depleting that bloodstream supply of arginine, that can slow tumor growth. So I'm very excited about this particular drug. It's really a brand new mechanism of action. There's really no comparable product that's ever been tested in GBM. A similar kind of molecule was a mainstay of pediatric leukemia treatment called L-asparaginase, that some folks may have heard of, but this is an arginine depleting enzyme. It's a different amino acid. So we'll see, we'll be getting this going later in the year. And then for other therapies, we have some biotech companies, as I mentioned. One company that we're excited to work with is Arcus Bioscience. They're running an immunotherapy study in recurrent glioblastoma patients with experimental products called AB154 and AB122. The study has had 2 phases so far. The phase 1 was an open label study of this compound, which is close to enrollment, and it's now graduated onto phase 2, where a study drug is given preoperatively. Patients then undergo a second surgery for their GBM, and then they do receive the drugs open label. Then it's known you're receiving both of the products for the study, and then you would continue taking them until the time of progression. We've been seeing what I believe to be encouraging results in this trial so far. We've had a good enrollment rate for it. And this study was really based on science that was originally done at Yale. Government NIH-funded research to Dr. Hafler's lab, our chairman of neurology, led to the discovery that a molecule called TIGIT is important for immune system function in the brain. And in patients with multiple sclerosis, TIGIT is underexpressed or has low levels. And in glioblastoma, TIGIT is overexpressed or has high levels. And we think that by blocking the TIGIT effect in glioblastoma, that can activate the immune system to fight back against the GBM. So again, we're in phase 2 of this study right now, and I'm excited about this product. It's one of our lead studies, and Dr. Moliterno has really also been an outstanding proponent of the study. Is clearly involved in the re-resections or second surgeries for our patients. And we have some other clinical trials for other brain tumor types. And beyond gliomas, we have studies for grade 2 meningiomas, study for newly diagnosed patients with grade 2 meningiomas called the NRG study, which randomizes patients to receive postoperative radiation or observation. And we have a study for recurrent atypical meningiomas sponsored by the Alliance Consortium, looking at drugs that have different molecular targets, An arm is open for meningiomas that have an AKT1 mutation. There's also an arm with patients with NF2 mutant drugs. It's currently closed. We have a study of another drugs in craniopharyngioma, a rare brain tumor near the pituitary gland. Study with a drug called tirabrutinib for CNS lymphoma treatment, newly diagnosed or recurrent. We have a study coming online for a treatment of diffuse midline glioma, or DMG, another rare brain tumor that generally affects younger people, looking at a drug called ONC201. This is a phase 3 study that, if positive, will lead to the regulatory approval of ONC201 for treatment of this disease. We were involved in phase 2 efforts and an expanded access program in ONC201 over the past few years. So I'm excited to lead this up with our Yale team. We'll actually be opening it to enrollment tomorrow, as a coincidence. And then we also have studies for brain metastasis patients through our disease team, and also the other disease teams like melanoma and thoracic oncology. Yale is also a member of some consortium groups that are coming together this year. One group is called the Glioblastoma Therapeutic Network, or GTN. This is also funded by the NIH for large institutions. We're collaborating with Mayo Clinic in a center called the Center for Innovation of Brain Tumor Therapeutics. And there are drugs that are currently being studied in lab models, which we hope to bring into people in phase 1 studies. And the Glioblastoma Therapeutics Network is going to be the mechanism to do that at our hospital and these other hospitals listed. And a second consortium called the DNA Damage Response Consortium has also been announced. Yale is leading up the effort for this. This is an effort to focus on drug development, taking advantage of the MGMT methylation status, as like earlier question alluded to. And this is being primarily funded by the National Brain Tumor Society, or NBTS, group that I've been involved with, and I really think they're tremendous. They're doing a great job with national advocacy as well, and supporting legislative efforts to improve the lives of patients affected by brain tumors. And in conclusion, the new treatments are developed through clinical trials, and we have an exciting portfolio for our glioma patients, and also really all of our primary brain tumors. Our team meets weekly as a research group, and during these meetings, we identify potential patients for study, review patients on treatment. We discuss new trials, where studies are in our activation process. And we do have a number of studies which I didn't go over, but that are in the activation process. We'll end there. You can follow us on social media if you don't already. I'm on Twitter at Nicholas Blondin, and Dr. Moliterno uses Instagram at Jennifer Moliterno. Dr. Barden has also recently joined the Twitter crew, but I'm not sure what her username is on that yet. But I do know we are friends.
That was really outstanding. Thank you, Nick. Thank you, Mary. Really great overview. I know there's been some questions in the Q&A which have been answered. People saying thank you in the chat. Are there any other questions?
Ooh, I do see one other. I have a vestibular schwannoma.
Oh,
Any new information on those? Yes, I didn't touch on those, but Dr. Moliterno, I really is an expert in the schwannoma treatment. I guess I'll let you comment on that.
I actually, I have it. Any new information on those? I mean, that's a whole other topic, and we have run webinars closely associated with the Acoustic Neuroma Association. But mostly the modalities for management are still observation and open surgery and radiosurgery, and even a combination of all of the three. And we had published with the Acoustic Neuroma Association about a patient-centered approach, meaning that really for tumors that could be treated with any of the modalities that we have, having the patient's preference and having the patient's thought involved is really most important. Of course, there's some tumors that can only be amenable to surgical resection. And then, there's others that can be a combination of radiosurgery and open surgery, or might just be amenable to radiosurgery. So that's a larger discussion and conversation, but one that we can certainly have again in the future.
As I would add on the medical on neuro-oncology side.
I was just going to
the,
say too, go ahead, Nick.
Avastin has been studied in phase 2 clinical trials and seems promising. Dr. Scott Plotkin in MGH has really been leading up that effort nationally for over 10 years. And I do collaborate with Dr. Plotkin actively. We have a few patients kind of that I'm co-managing at Yale with MGH. But we really reserve Avastin for patients that are felt not to have further surgical or radiosurgery options for treatment. But it does seem like this may be a promising drug. I think that efforts will be underway to collect even further data on this.
And that's certainly, of course, thinking in terms of NF2 syndrome and hearing preservation. There's been a lot of work done with that. Are there any genetic testing for predisposition, like in colon cancer? Yes and no. So I think most of the tumors, in short, that we talked about tonight, we're talking more about ones that occur sporadically, that are not inherited. There are some tumors, including schwannomas and including gliomas and certain types, medulloblastomas that can occur in genetic syndromes. But for the most part, there's no markers that we usually use to screen patients for these, not yet at least. Also, I know Dr. Blondin had mentioned that we meet weekly in a multidisciplinary tumor conference, and we do. We also have a precision brain tumor conference that piggybacks onto that clinical conference. And all of our tumors at Yale undergo what we call whole exome sequencing, which really allows us to understand all the mutations that are making up the tumor, causing it to grow, and allow us to really think about these tumors at a more precise and personalized level. But again, that's the genetic mutations that occur more so in the tumor than ones that are passed along from generation to generation.
Our whole exome sequencing can potentially identify a hereditary cancer syndrome, like Lynch syndrome. We find there are certain mutations, such as the MSH or MLH mutation associated with Lynch syndrome. And if we find that on the whole exome sequencing, then we can subsequently look at the blood for that patient and identify it that way. So actually through our whole exome sequencing done on all our brain tumor neurosurgical resections at Yale, we do pick up like hereditary cancer syndromes rarely for patients. But Lynch syndrome, it does have an increased risk of development of IDH mutant tumors. So I have picked up a couple patients through our molecular screening process.
It seems a lot of other people are saying thank you to the two of you for your excellent presentations tonight, and they found this really beneficial and helpful. And this is something that we will certainly do again. We do it at least once a year, and moving forward, we can even hold it more frequently and even do subtopics with acoustic neuromas or other types of tumors. So I hope this was helpful. Thank you again to Dr. Blondin and Dr. Barden. Really wonderful to work with both of them, and they take such wonderful care of our patients.
Thanks so much, Dr. Moliterno. There will be a recording of this, and that information will get sent out, I believe, at least through the social media channels for the link on the recording.
All right. Want to wish everybody a good evening. And also give a shout out to our Connecticut Brain Tumor Alliance friends who I see on here as well. So have a good night.
Thanks for joining.
All right. Thanks, Nick. Thanks, Mary.
Bye.
Bye.